Good afternoon, everyone. Happy Wednesday. I'm Dr. Reinhardt, Michael Reinhardt, the director of our Brooklyn Initiative to Develop Geriatrics Education, or BRIDGE. And it's my pleasure to welcome you all today for this session on diabetes care in older adults, a 2021 perspective, a really important clinical entity that affects all sorts of outcomes, cognitive and physical, for our older patients. This lecture is one of a series that Bridge is providing that will support our activities as well as the activities of our new Advanced Certificate in Public Health Geriatrics in the School of Public Health. And we'll also be using this talk afterwards to create an online learning module for continuing education regarding geriatrics for Brooklyn's providers. So it's our pleasure today to welcome Naushira Pandya to speak on this important topic. Dr. Naushira Pandya is a professor and chair of geriatrics, the Department of Geriatrics at NSU, Kiran C. Patel College of Osteopathic Medicine, and the project director of the HRSA-funded NSU South Florida Geriatrics Workforce Enhancement Program. She's board certified in internal medicine, geriatrics, and endocrinology and metabolism, and is a certified medical director and a geriatrics fellowship program director. Dr. Pandya has created a thriving academic and clinical department comprising nursing homes, medical director leadership, ACGME accredited geriatrics fellowships, a consultative service, 2 geriatrics clinics, as well as strong interprofessional, institutional, and community partnerships integral to her work in elder care, as well as the Geriatric Workforce Enhancement Program. She was instrumental in creating geriatric medicine fellowships at Broward Health and Aventura Hospital Medical Centers in South Florida. And at a state level, she's second vice president of the Broward County Area Agency on Aging and past board member of the Florida Society for Post-Acute and Long-Term Care Medicine, and remains active in governance issues affecting the post-acute long-term care setting. She's past president of the AMDA, the National Society for Post-Acute and Long-Term Care Medicine, and past chair of the Interdisciplinary Clinical Practice Committee. She has participated and led in the development of multiple clinical guidelines and position statements, and is recognized for her work in the area of diabetes in the elderly, as well as best practices in the long-term care continuum. On a national level, she participated as a panelist in the White House Conference on Aging and in the White House Conference on Antibiotic Stewardship, and served on the Physicians Advisory Committee for the National Quality Forum, and as a member of the College of Surgery Coalition for Quality in Geriatric Surgery. She also holds the distinction of being a Fulbright Senior Specialist Scholar. So without further ado, it's my pleasure to turn the Zoom microphone over to Dr. Pandya, and we'll be holding questions for the end of today's talk. And as a kind request at the end of this talk, you should be receiving an invitation to complete a survey regarding your experience today. And we'll use that survey to guide our future programming and continue to improve our service to the Brooklyn community. Thank you so much, Dr. Pandya. I'm looking forward to your talk today.
All right. Thank you so much, Dr. Reinhardt, for that kind and rather lengthy introduction. Thank you to all the Bridge faculty for inviting me and being so helpful and supportive as we got ready for this presentation. I'm going to give you a whirlwind tour of diabetes in older adults, and then you'll obviously have the material to look at it at your leisure and study specific aspects as you wish. Okay, let me just see if I can advance my slides. Okay, so my disclosure is I'm a speaker for Lilly, but there should be no conflict in the material that I'm presenting here today. The objectives today will be to look at the challenges of managing diabetes in older adults and review what the glycemic goal should be and how do we approach the management in older adults with a view to their health status and their comorbidities. The area of hypoglycemia is very, very important. It's taking center stage now with older adults, and we want to look at strategies to avoid it while avoiding extreme hyperglycemia. We're also going to look at pharmacological treatment with a focus on improving cardiovascular outcomes, because there have been a lot of recent changes in diabetes management with a view to improving cardiovascular outcomes. And then I'll just touch on improving long-term care processes and management of diabetes patients, and to look at how we can improve care transitions. So diabetes affects older adults disproportionately, over a quarter of over 65-year-olds. And in the long-term care setting, almost 1 in 3 patients can have diabetes, depends on the locality and the long-term care population. Non-white residents are disproportionately affected. And the problem with diabetes is, and we all know this, those patients have a high number of co-morbidities. They're prone to go to the emergency room, pressure ulcers, cardiovascular complications, infections, and the cost, even in the early part of this decade, was very high. Excuse me. And also increased hospitalizations. People with diabetes are prone to increased number of hospitalizations. So what is it about older adults with diabetes? Well, it's difficult because they're a heterogeneous population. That clinically, each one can be different, functionally different, cognitively, socioeconomically, and what the support is in their site of care. Of course, comorbidities and their goals of treatment are also different for each individual. And we need to focus on how do we reduce existing progression of complications? How do we improve quality of life while we're paying attention to patient preferences and their values, and making sure that our treatment is not actually harming patients? So older adults carry the diabetes burden for a long time. If you look at the graph on the left, those over 80 years old have had diabetes for over 10 years. And of course, that means that they've also had complications. In fact, at the time of diagnosis, 50% of people with type 2 diabetes have existing complications. And the people with diabetes are more likely, obviously, to have complications, and that's shown on the graph on the right. And this addresses adults over 65 years old. So you can see that not only do we have geriatric syndromes and aging problems to contend with, but people with diabetes who are over 65 have more already have macrovascular and microvascular complications. And just for clinicians, I bet you've never seen a patient with just one diagnosis on their list, right? Type 2 diabetes. They carry baggage, as I call it. They're more prone to autoimmune disease, especially those with type 1, who are now getting older, and we're taking care of type 1 patients. Hypogonadism, oral health, sleep apnea, and now cognitive impairment or dementia and depression are really considered as complications of diabetes in those who have diabetes. And of course, they're prone to fractures, GI disease, and hearing impairment. So let's first look at challenges of managing diabetes and how to individualize care in older adults. I wrote this a few years ago. I was writing a chapter, so I tried to break down the challenges in terms of age-related factors. So you'll see, decline in renal function, altered glucose metabolism, functional impairment, sarcopenia, frailty. Hand dexterity is particularly important, as is vision. But then staff and practitioner challenges, we are actually part of the challenge. We're part of the problem, I feel, in people with diabetes. Because our knowledge varies, there's often lack of team communication or communication between the primary team and specialists. There's a little bit of therapeutic pessimism. When we are in an institutional setting or in the clinic, we fail to review glucose logs, we rely on A1C. And one of the big problems is we don't advance treatment in a timely manner. The other challenge is health and psychological factors. Obviously, older adults have multiple comorbidities. They may have cognitive impairment or depression, anxiety, Access to healthy food may be variable. They suffer from the effects of polypharmacy. They're at risk for hypoglycemia. And there's this true entity of diabetes distress, which is measured by several validated tools. How well can the patient cope with this disease and manage the self-care that it requires, the preventive health that it requires? And then socioeconomic factors, which you can see: access to food, health insurance problems, limited income, prescription expense. Health literacy is particularly important, especially as diabetes technology is advancing, delivery systems are complex, and then the site of care. Every site of care provides a different level of support for older adults. There can be assisted living settings with ability to measure glucose and give insulin, and other assisted livings cannot even measure blood glucose, depending on their license. I want to just touch on some unique syndromes that may occur, and it may be difficult to recognize the person with diabetes. They can present, as I show on the left, with failure to thrive, confusion, worsening incontinence, infection. It can even present as an MI or dehydration. And some of the rarer syndromes are shown on the right: diabetic neuropathic cachexia, neuropathy with weight loss, depression, really a failure to thrive. Neuropathy we're familiar with. Capillary necrosis can present with gross hematuria. Painful diabetic amyotrophy, which if anybody's seen is a very hard condition. Shoulder pain, diabetic bullae on the palms and soles of the feet, osteoporosis. And in this day and age, we are well aware that people with type 2 can also develop diabetic ketoacidosis, and those who are on SGLT2 inhibitors, such as canagliflozin, can have euglycemic ketoacidosis. So this diagram just briefly shows an algorithm developed by Alan Sinclair and his colleagues in the UK on how to assess a patient. And I won't kind of go into this in detail, but just suffice it to say, when you see an older person, the initial detailed assessment is terribly important. Look at their functional status. What are their cardiovascular risk factors? Do they have kidney disease? And then what's their nutritional level? And so you complete a comprehensive assessment, and then you decide on the risk benefit of the agents you're going to select to treat them. Are you going to try to reduce complications? How can you improve functional status? And by so doing, you set their glycemic goals, and you put them into one of three health categories, which I'll show you. And that leads more to an individualized plan of care with meal plans, which are really liberalized. People with diabetes no longer need to be on a diabetic diet. Carbohydrate consistency is important. And I often say they just need to be on a real food diet. Okay. So the recommendations from the American Diabetes Association on the management, I'm just going to minimize the participant screen because I'm having a little trouble looking at the whole slide. So in 2016, I participated in a position statement by the ADA on diabetes in long-term care and skilled nursing facilities. And the key recommendations were to try and reduce hypoglycemia as you determine glycemic goals, simplify the regimen, avoid the sole use of sliding scale, liberalize diet, fluid and food intake, and promote physical activity to the extent possible. This is my own take on the 4M age-friendly framework on older adults with diabetes. So what matters, I looked at quality of life, treatment preferences, what kind of existing complications, social support. Medication speaks for itself. What type of diabetes? Do they have hypoglycemia? Do they have end organ disease? Mentation, I've spoken about this already. And mobility. So I feel that this 4M framework really lends itself to people with diabetes, and it assesses the function, cognition, co-morbidities, and also values and preferences. So I am just trying now a little bit more consciously to look at my patients with diabetes with this framework in mind. And I hope that maybe this helps some of you.